All right, good afternoon. Good afternoon, everyone. We're going to go on and get started now. It's a few minutes after 4, and we'll probably have some people joining us late, and they'll come in through the back. And if you need to leave early, you can do the same thing. So thanks very much for being here with us. I'm Elena Marks, and I'm a senior fellow in health policy here at Rice University's Baker Institute. And I'm part of a group of fellows who work on U.S. health system transformation. If you've joined us tonight, you're likely aware that the U.S. spends more than any other country, whether you count by total dollars or GDP or per capita spending on healthcare, than any other country on the planet. And at the same time, our health outcomes are worse than other developed countries in important metrics like life expectancy, maternal and infant mortality, and obesity. Our health system transformation team focuses on how we get the value we deserve for the $4+ trillion a year we spend on healthcare. We look at how we can reduce costs and how we can improve outcomes so that we can actually benefit Americans that in a way that equals the cost that we pay for all of this care. Tonight's discussion is an important part of the conversation on value because of the outsized roles that hospital systems play in our system. Hospitals account for 1/3 of U.S. health spending, so that's almost $1.4 trillion a year that go to hospitals. And for that reason, we look really carefully at how they use their resources. Most hospitals across the country are nonprofits, and across Texas and in Houston, our largest systems are nonprofits. Nonprofits have a special legal obligation to benefit their communities that goes beyond providing medical services. They have this obligation because they're excused from paying most state, local, and federal taxes. Today, you'll hear about how hospitals are fulfilling their community benefit obligations and how hospitals can help improve community health by moving dollars upstream into communities to reduce the underlying causes of poor health. So with no further ado, I'd like to introduce my colleague, Xiaoqi Sim, who is also a fellow at the Baker Institute, and his day job is as the Vice President for Research, Innovation, and Evaluation at the Episcopal Health Foundation, and EHF is our co-sponsor for this event, so you're in for a great session tonight.
Great. Thank you so much, Elena. It's kind of interesting now we have our role a little bit different. Where before we, used to be colleagues. Well, we still are colleagues and a trusted, very respected mentor and coach for many of us at the foundation. What I'm going to do a couple of things. Let me kind of like run down in terms of what the agenda looks like today. Give you a sense of what to come. After my brief introduction, you'll hear from Dr. Jose Figueroa from Harvard School of Public Health and Harvard Medical School in terms of what we consider some really, really important and groundbreaking data in terms of the work that he has done looking at hospital spending on community benefits. And then we have two very, very important and experienced thought leader, healthcare thought leader in our states. We have Ms. Carol Perret, who has been for so many years, work at the helm of the Community Benefit Corporation at Memorial Hermann Health Systems. We also have Dr. Ryan Van Ramshaw, who's the Chief Medical Director at Texas Health and Human Services Commission, the Medicare and CHIP Services division. They're going to give some response to Jose's presentation, and then I will then facilitate. I'll probably just going to ask a couple of questions to both the presenter and the panelists, and we will open it up for some audience Q&A after that. If there's still interest and if you feel like we are not, you haven't been able to ask your questions, we also have a reception after this event from 5:30 to 6. So feel free to reach out. With that said, as Elena had mentioned early on, this is really a partnership between the Bakers Institute as well as the Episcopal Health Foundations. I'll just give a little bit of kind of like what the foundation, a little bit of an overview of the Episcopal Health Foundation. At the foundation, we believe that all Texans deserve to be healthy, no matter who they are, where they live, or how much money they make. We are also committed to transforming the health of our communities by going beyond medical care alone. At the organization, we provide millions of dollars in grant making, but we also work very actively and intentionally with our congregations and community partners, as well as providing timely and important research where we are trying to support solutions that address non-medical underlying root causes of poor health. And I think just, being able to highlight this issue of hospital, the role of hospital and health system in addressing social determinants of health, take on such a, important or significance in our states, given that, we are a state with the highest uninsured rate. We also, is very, very large states, with a lot of health and healthcare challenges. So with that said, we'd like to bring up Jose, and let's get the program started. Thank you.
Thank you so much, Xiaoqi, for the invitation, and to Elena to be here. It is a pleasure to be here today. And I want to start the conversation by reminding everyone here that depending on where you live, life looks very different. There are some parts in our country that the average life expectancy is as low as 56 years of age. And in other parts of our country, people have the luxury to live to nearly 100 years of age. And just by looking at this map, red means lower life expectancy and blue means higher life expectancy. Everybody can guess where these communities are. There are communities with higher proportions of Black people, higher proportions of Latino people, and in some areas, white rural America as well. And what a lot of people have heard about is that in our country, the $4 trillion, we spend more than any other high-income country, or more than any other country in the world for everything we do. $4 trillion a year spent into our healthcare system. And if you look at the data suggests that the healthcare system, unfortunately, only determines about 20% of our total health. And the rest is determined on where you live, the type of education you have, whether you have support at home, your income, whether you live in poverty, and how safe your neighborhood is. It's also determined by your lifestyle in terms of whether you smoke, whether you exercise, whether you have access to healthy foods, and whether you engage in unfortunately a major issue that is currently a pandemic in the middle-aged population of our country, drug use and alcohol disorder. And so when we talk about the amount of money that our health systems are getting, we have to ask the question, what role are they playing to address the issues of the social determinants of health? And if you look at some recent data, it suggests that health systems are becoming increasingly aware of these issues, and they're engaging in trying to address the needs of the patients and their communities. And one estimate suggests that just between 2017 to 2019, across 917 health systems, over $2.5 billion have been invested in trying to address issues such as housing, transportation, employment, issues related to educational attainment in their communities, and then importantly, food security as well. Now, one thing we have to talk about is that the majority of our country, of the people living in poverty, are taken care of by our healthcare safety net system. If you look at a report in 2000, there was a summary of this. There was a big review, an investigation into the state of the safety network in our system. And in it, it says that our country's safety net, this is in 2000, is a patchwork of providers, of funding and programs that are tenuously held together to meet the needs of the majority of the low-income people in our country. And at that time, the report concluded, this is from the National Academy of Medicine, is that the safety net in 2000, it is intact, but it is endangered. Now, fast forward 23 years later, and the same arguments and the same concerns in that report exist today. We have a problem of a segregated healthcare system in our country, that the poor are often cared for by a very small group of providers and a very small group of clinicians. 80% of the low-income population living in poverty is cared by just 20 to 30% of clinicians and health systems. And that safety net is under-resourced and financially constrained, and that system has substantial staffing shortages and higher rates of clinician burnout. And so the system is still intact today, 23 years later, but it is still endangered. Now, there's been a lot of recent trends that have threatened the viability of our safety net. Number one is reimbursement is lower for the care of low-income people. To put it bluntly, on average, hospitals that take care of Black people get paid less. On average, hospitals that take care of Latino people get paid less. And that is because they're disproportionately in plans like Medicaid that reimburse less for the care that the hospital delivers. They're also more likely in low reimbursing commercial plans because on average, low-income populations don't have the luxury of working for a Fortune 100 company that has very generous benefits. The other thing that we know is that the safety net, 8% of the nation is currently uninsured in our country, and they're concentrated in the safety net system. By the way, 8% is the lowest uninsurance rate we've ever had in our country, ever, in the existence of our country. But if you compare it to every other high-income country, like England, like Canada, Germany, the Netherlands, almost every European country, the uninsurance rate there is 0%. So 8%, even though there's reasons to celebrate for it to be the lowest ever, it is still lagging internationally behind every other major high-income country, despite the fact that we pay twice as much as our nearest neighbor in terms of healthcare. Now, this is different in the state of Texas, where nearly 1 in 5 of the population is uninsured. It is the state with the highest uninsurance rate. The other thing to note is there's been a lot of excitement over the last decade around the idea of value-based payment reform to increase accountability of clinicians and providers. We're paying them a lot of money, and we should hold them accountable for the quality of care. But unfortunately, that system is potentially undermining the safety net, and I'll go into a little bit more about it in a second. And then the last thing I'll say is the ability to recruit, train, and staff the safety net workforce is a major issue. Issues with retention, issues with wages, issues with turnover. The safety net system is often one where people go, they get young nurses go, they train, and then they go to higher paying jobs. So unfortunately, really hard to recruit. Now, over the last few decades, or really in the last decade, for one, there's been major efforts to help the safety net, both at the federal level and at the state level as well. And I'm going to talk about two different policies that are meant with the intention of helping the safety net by providing resources to take care of their vulnerable patient population. And one of them is through the value-based healthcare reform movement, through the Affordable Care Act. And another one has been one that's been around for a while is the nonprofit hospital designation. So I'll talk about value-based reform first. In the last decade, since the Affordable Care Act has passed, over 30 value-based payment models have been implemented. There's pay for performance for targeting hospitals on readmission rates, on reducing their hospital-acquired infections, on improving patient experience, on reducing patient mortality for commonly treated conditions. There's been pay-for-performance efforts targeting nursing homes, targeting home healthcare agencies, targeting dialysis centers. Over 30 programs have been implemented. One thing that the majority, nearly all except one, have in common is that there is absolutely no accounting for the underlying social risk of the patient population. And we started this conversation talking about that social determinants matter. Social determinants influence health outcomes, but in these models, there's no accounting for the underlying social risk of the population. And unfortunately, across all of these models, time and time again, every evaluation, both independent and even ones from the government, have shown that safety net hospitals and hospitals that serve more Black and Latino people are more likely to be penalized across all of them. The other thing to note is that some of these programs are zero-sum games, where the penalties from one institution, the quote-unquote, the ones that are underperforming, the losers, are taken and given as bonuses to the winners. And if you look across the board, there's evidence to suggest that a lot of the money that was supposed to go to the safety net is given as bonuses to predominantly white-serving health systems, and predominantly health systems that tend to serve more people from who are more educated and are wealthier. And so there's concern for structural racism in some of our value-based healthcare policies, or structural discrimination that is unfortunately potentially harming the safety net system. Now let's talk about the nonprofit hospital system. In our country, nearly 60% of hospitals are nonprofit. That means, as was mentioned earlier, they are exempted from paying federal taxes, state taxes, and local taxes. But they're, with one stipulation, they're required to invest in charitable giving and benefit their community. Now, what is the definition of community? And that is unfortunately an issue that we'll talk about in a second. And there's also no minimum requirement in terms of the amount of dollars that, for most states, that go back. Texas does have a requirement, which we'll talk about in a second. So how much money is staying with health systems that would have been taxed, that could have gone to local governments, the state government, or the federal government? If you look in 2011, about $19.4 billion are staying with health systems that would have been taxable had the governments collected it. In 2020, that number is $28.1 billion. This is an estimate from the Kaiser Foundation. So it is an increase of 45% just between 2011 to 2020. A lot of dollars are staying with health systems. If you think about where those dollars would flow, about $14 billion in 2020 so about half would have gone to the back to the federal level, and about half would have stayed in the local and state level. So there are some requirements that hospitals have to do with it, as part of having the charitable nonprofit status. One is that they need to be engaging with their community in some way, shape, or form. Most hospitals do this by conducting a community health needs assessment every 3 years. Another one is that they must provide essential medical services regardless of the ability to pay. So hospitals, so this include people who are not insured. And the third most important one that people often think that hospitals are doing is how much are they investing in the public health of their communities and in addressing the social needs of their patients and their populations. So for example, spending something on the Harris Health System food pharmacy program would be an example of an SDOH type activity that a hospital might be engaging in. Now, if you look at the national trends and try to break up these dollars in terms of what hospitals are reporting across the different activities, the biggest one, I'm just going to review a few. There's a long laundry list, but the biggest one, which is this maroon color, is the Medicaid shortfall, which is hospitals are saying we are taking care of a lot of Medicaid patients, and we are losing money on Medicaid patients because we're not getting paid what we think we should be getting paid. And so whatever the shortfall, the gap between what they say treating a pneumonia costs for and what Medicaid pays for, it's included as a community benefit. This is really controversial. This is really controversial because of the fact that it's based on what hospitals charge. And there's problems with the hospital charge because it's sort of a made-up number. It's not really a true cost number. And so hospitals have an incentive to say we charge as high as possible for the pneumonias and for the knee replacements. And for the higher they charge, the more money they can report as a community benefit. The second is uncompensated care. This is for taking care of people who are not insured. Now, no one would argue against this one, I don't think. It's like there's people who come into an emergency room, they don't have insurance, which again is around 19% of the population in Texas. And there's a way for them, they say, like, this is the amount of uncompensated care. We weren't reimbursed for this. Now, there's an argument against this one for the nonprofit tax designation because there's already a system across states to get reimbursed for uncompensated care, and that's through the DISH payments, disproportionate share hospital payments. The second and the third and fourth one, interestingly, hospitals can count health professional education and research as a community benefit. So, for example, every year I have a pot of money so I practice clinically at one of the hospitals in Boston. And every year I have a pot of money that I can go to a medical conference, I can take a class, and the hospital pays for it, and it's counted as a community benefit. And so so health professional education and research is being paid by the US tax dollar. And then what people often think about actual dollars flowing into a community is really small. It is way at the top in a second. Now I'm gonna go a little bit deeper into this in a second and start giving you the Texas look versus the rest of the country. So the one thing is there's a lot of controversy surrounding the nonprofit hospital status. Just today, Elena forwarded an article written by Don Berwick calling out the nonprofit hospital status designation. There's an independent group called the Lown Institute that suggested that they're concerned that 80% of US hospitals are spending much less on charity care and community investment than the value of their tax dollars, which is reflected in some of the graph I just showed. On the other side, there's a lot of groups who are arguing that the nonprofit hospital status system is worthwhile. But the group, one of them is the American Hospital Association, who may or may not be biased in promoting this report. And they said, like, actually, no, the nonprofit hospital designation, we're providing 9 times higher benefit than the actual worth of the tax exemption. But one thing is there's about 40% of hospitals in our country that are for-profit. For-profit hospitals take care of a lot of Medicaid patients, and for-profit hospitals also take care of a lot of uncompensated, uninsured patients. And then they get the state mechanism through the DISH payment. There's some dollars that flow back to the for-profit hospitals. And this study suggests, there was a study published recently last year that suggests that nonprofit and for-profit hospitals have the similar amount of unreimbursed Medicaid costs as the share of their total expenses. So the argument that nonprofit hospitals often make maybe does not hold water because for-profit hospitals have that same exact issue. Now, this is a controversial statement. I'm sure there's a lot of hospitals here or hospital representatives that might come attack me after this, but it is a controversial, but at least it suggests that the argument that we are providing subsidized care for Medicaid beneficiaries and that's why we should not be taxed does not maybe hold water because for-profit hospitals are doing fine and they're taking care of the same amount. Now, let's talk about Texas and what Texas is doing to address the social determinants, but we're gonna keep it to the community benefit spending. And so what we did, thanks to the support of the Episcopal Health Foundation, Elena, you were still there, and Xiaoxi, thank you for supporting us, is how does Texas compare to the rest of the country? So what we did is we looked at about almost all nonprofit hospitals in our country. We pulled IRS data. We went through all of the 990s and then attributed every single dollar that hospital spends on community benefit. And we attribute it differently than prior research. Prior research basically just looks at the zip code of the hospital and attributes all of the community benefit dollars to that zip code. That's a problem. I mean, you can just walk to the Texas Healthcare Center, and it would be that type of research attributes all of the dollars to just the zip code where all the hospitals, which doesn't make any sense. And so what we did is we flowed back every single dollar to a per person basis back to the communities. And so this is a better estimation because, Memorial Hermann serves different patients than Ben Taub Hospital, and we're tracking back to the individual person's zip code. So how does Texas compare if you look at total dollars of community benefit spending? Just to remind you, this includes spending that they're reporting on subsidizing Medicaid, on subsidizing uncompensated care or uninsured care, on my medical education, public health issues, community partnerships, and then importantly on the non-medical drivers of health or the social determinants of health. First key point, Texas communities receive 40% less than the national average. On average, $131 per person flows into Texas communities. The national average is about $218. This is, again, across all of those categories. Fewer dollars being spent in relative to the community benefit spending. Now, this is just, somebody earlier had brought up this point. This is not a large hospital versus small hospital because we're attributing the dollar to the per person level. So large hospitals and small hospitals are being weighed essentially the same. More yellow means more community benefit dollars. It's among the highest in the country. And more blue, darker blue, means fewer community benefit dollars at a per person level flowing into that community. Now, what about if you were to ask questions about the type of communities that those dollars are flowing into? And just in terms of the key findings, there's a graph here, but just the key findings from this graph, the more left, and then there's different categories there. So for example, if you go here, it's the percent non-citizens. So the more people who are non-citizens, the more left, the fewer dollars as that percentage of that goes up. Here, percent Hispanic, the higher the percent Hispanic in a community, the fewer the dollars flow into that community. So key findings is poor communities and less educated communities are currently receiving fewer dollars, community benefit dollars. The more Hispanics in the community and the more Asians in the community receive fewer dollars than the more white communities. And one thing I'll say is that Texas actually looks better on this measure of total community benefit on average in terms of the allocation across vulnerable communities versus less vulnerable communities. Not in terms of total dollar amount, there's fewer dollars, but relatively it suggests that the Texas is the red dot with the confidence intervals around it. They're closer to the middle. That means that Texas maybe is allocating resources slightly better than others. But again, this includes Medicaid and uncompensated care, Medicaid subsidies and uncompensated care subsidization. But again, there's concern that unfortunately this system there's fewer dollars flowing to the communities that need it the most. And why is that the case? Because if you think about it, community benefit spending is really just dollars that the hospital makes taking care of people. If you're a hospital that on average is making less money taking care of more socially vulnerable and disadvantaged populations, you have fewer dollars to play with. And so there's fewer dollars actually flowing into the communities that arguably need it the most. Whereas if you're a hospital that takes care of a lot of wealthy people and are making a decent profit, you have more dollars to play with and invest into the communities that arguably need it the least. Now, let's take away the Medicaid shortfall and the uncompensated care and just look on the amount of dollars flowing into the communities to address specifically issues around the social determinants of health. Examples including addressing issues of housing insecurity, food insecurity, economically developing their local communities, environmental improvements, including fixing roads, putting up parks, helping the workforce, and community building, coalition building. The next key finding is that less than 1% of dollars that hospitals say they're doing in community benefit spending actually is being spent on those things that we call community, like actually community benefit. The majority of dollars are on the Medicaid shortfall, which again, there's an argument that they maybe don't need it because for-profit hospitals are doing fine. Texas has more for-profit hospitals than the national average, by the way. So that's it. And then the other thing to note is that, again, Texas is lagging behind the national average. Only 55 cents per capita are going into these communities to address the social determinants, which compares to $1.22 nationwide. Now, why could that be? Why is Texas lagging behind? And actually, I'll just show you one more graph. The same findings hold. The more poor communities and less communities are receiving fewer dollars to address the social determinants of health. And again, Hispanic communities, especially in Texas, are receiving fewer dollars to address the social determinants of health. Now, Texas, the green is more left, meaning it's even worse in terms of in terms of the allocation to vulnerable communities to less vulnerable communities. And one reason here is because a lot of the community benefit dollars in Texas are flowing to deal with the uninsured population in the country, or in the state, which is higher than every other state, and also for dealing with a lot of Medicaid people. And there's a huge number of Medicaid people in the state of Texas. So even though overall, if you look at total dollars, they look maybe better than the national average on addressing social determinants, they look slightly worse. So I'm just going to share a couple more slides and then I'm going to pass it over to my colleagues for their comments. I just looked at community benefit spending dollars, but what are hospitals specifically doing to address the social determinants of health? And there's a national survey that we published the results. Again, thank you for the Episcopal Health Foundation for funding this work. What are hospitals doing across 3 domains? The first one is, how often are they screening for health-related social needs? The second is, not only are you screening, but do you have programs and interventions to address the social needs? And the last thing is, what are you doing to partner with the community? Now, this is some detailed survey methodology. In terms of screening for SDOH, they asked about 9 different types. This is a national survey from the American Hospital Association. They ask whether you screen patients for issues of housing insecurity, food insecurity, whether you have trouble paying utility bills. They ask about domestic violence issues, whether they're surveying their patients about whether they have lack of transportation, employment, income, education, social isolation, and health behaviors. This is around, for example, alcohol use, drug use disorder. And then they ask whether you have programs and interventions to address those specific 9 determinants. And then again, whether you are participating with the community across 42 different types of potential community partnerships. They include partnering with local public health departments, partnering with schools or universities, partnering with local law enforcement, a long list of 42 potential different partnerships. I'm going to compare how Texas hospitals responded to the rest of the country. In Texas, 91% of all hospitals responded to this survey. This includes for-profit hospitals. And in the rest of the country, the response rate was 64%, so Texas is well represented. The first question, how does Texas compare in terms of, on average, Texan hospitals compared to the national average? They're about the same. They screen about, on average, the same number of social determinants of health. In terms of having programs and interventions, about the same. But in terms of reporting community partnerships, Texas hospitals are on average lagging behind in participating with community-based organizations to address the social determinants of health. Now I'll show another slide here. If you were to just ask the question, what about safety net hospitals versus non-safety net hospitals? We find that you would expect safety net hospitals to do being more across these 3 domains, but unfortunately they're not, and in fact they're lagging. They're actually less likely to participate in community partnerships. And then if you asked about rural hospitals are even less likely to participate across these 3 different domains. And it goes back to it costs money to do screening. It costs money to design programs and interventions to target your patients and your community. And it costs money to partner with communities. You also have to have the partners in the community to be able to engage with. So you could have an instance where a hospital does want to do something, especially for a rural hospital, but if there's no one in that community to partner with, you shouldn't be surprised that they're lagging behind. And so if I just go back to that, the original graph in terms of like life expectancy, and the red means people living to just 56 years, and the blue, the dark blue, up to 100 years. And if you look at the map in terms of how community benefit dollars are flowing, you can almost put this map on top of the other. In an equitable world, you would expect that the bright yellow, more community benefit dollars, to be matching where the greatest need is, where people are suffering, don't have the opportunity to live a long, healthy life. But it is backwards in our country. More dollars flowing to communities that need it less. And we shouldn't be surprised that we have certain communities in the US living to 100 years of age and others not even reaching the age of 60 because we're not matching resources with need. So I will end here because I think I'm at time. So thank you so much for your time.
Thank you so much for that wonderful presentation. I know there's probably a lot of you are interested to ask questions, but please hold off because we'd like to invite the panelists and Jose come up here so that we could have a more of a facilitated response and discussions about his research data. So I believe Carol or Dr. Wee, which one would like to start first to provide some response?
Well, good evening, everybody. Again, my name is Ryan Van Ramshorst. Most everybody calls me Dr. V because my last name is a bit difficult. Very proud to be the Chief Medical Director for Texas's Medicaid program. Thanks so much to the Baker Institute and Episcopal Health Foundation for extending the invitation. And Dr. Figueroa, thank you so much for this information. So my first reaction is I am not doing enough to help move the needle when it comes to addressing social determinants of health in the lives of the individuals we serve in Medicaid. But as I'm thinking about what policy levers can we pull from a state standpoint, I think this data is powerful. And when you're making policy decisions that have impacts on millions of Texans and can potentially cost millions of dollars, I think data is a really, really important place to start. And as I hear the presentation, I think there's just more that we could and should be doing. And so I'm wondering to myself, and would love to hear later on, maybe during the reception, what can we as the Medicaid agency be doing to help support these efforts? And just to share briefly, I know that Texas, especially in that presentation, perhaps did not come off in the positive light that we all think of our state being at some times, but you may know that our Medicaid program is a managed care Medicaid program. We cover about 6 million Texans now. We contract with Medicaid managed care organizations, health insurance companies, 16 of them to be exact, and they are in year 4 of a learning collaborative totally dedicated to advancing non-medical drivers of health in Medicaid. And so I think that type of work that is founded on collaboration and sharing best practices can really set the foundation for this work moving forward to better engage and bring in hospitals and health systems. I'll leave it at that.
Thank you, Ryan. Carol?
How many healthcare systems have renamed themselves health systems over the last years? They've taken care out. So if we're going to call ourselves health systems, we need to be health systems. And that means addressing the 100%, or at least the 80%, not the 20%. So we have to do it differently. And we have to put money behind those efforts. Because the reality is, hospitals complain about the Medicaid shortfall, they complain about uncompensated care, but we could reduce that significantly if we addressed issues much further up the stream instead of waiting for them to exacerbate. So we have to put money in different places, and we have to do that with community. I will tell you, in the communities that we work in, they know what they need. They know what they want. We don't have to come in and tell them. we shouldn't tell them because we don't know. And if we listen to them, you will see them engage and you will see them change what they're doing and how they're doing it, and you will see them take ownership. And when communities take ownership, that's where you get the wholesale change. So we know how to do this. We just have to do it at a very different scope and scale than we've been doing it.
So, reflecting on Jose's data earlier, I mean, the one image that struck me the most was, when you had talked about, think about how much hospitals are taking credit for, their community benefit spending in continuing medical education, right? In uncompensated care, so on and so forth. But the last line of your statement was about how little they are spending on some, real serious upstream challenges, transportation, housing, job training, so on and so forth. And I'm just kind of curious, whether from your perspective, Jose, as a researcher, as a health policy wonk, or Ryan and Carol, all kind of work in various type of leadership role, in government as well as in hospital setting. What does it take to change the heart and the mind of hospital CEOs, hospital boards, for them to really come around and look at this as, hey, this is a true win-win for all of us. That it's just not about bottom line at the end of the day. So I don't know if Jose, you want to get started on that? Yeah.
There is a terms of distribution in terms of there are examples of hospitals that are truly investing in the community, and maybe Carol can speak to some of her prior work or current work. But if we were to start from the beginning, and if the idea is to be redirecting resources to communities that need it the most, I don't think many of us would design the nonprofit tax system the way it is currently designed. Because if you think about it, the money and what's decided in terms of how that money should flow back into the community rests with hospitals. Hospitals are already getting a lot of our GDP. And so why are we also allowing them to dictate what every other business, all business gets taxed, and then it is up to local, state, and federal governments to figure out how to do with those dollars. So imagine instead of the $28 billion in 2020, instead of staying with the health systems, imagine what would have occurred if it was in the communities. They're meant to serve the community. And we're talking essentially who has power to dictate what is done with the funding. And the power dynamic would shift substantially if the communities had that pot of money, and the communities, which Carol just mentioned, know where their needs are. They dictate who the partners would be. Hospitals and health systems would come to the table very differently than they're currently coming into the table. Because right now it just feels like it's an accounting exercise, and it's not truly dollars flowing into the communities that need it the most. But
yeah, any tips or advice on changing hearts and minds of hospital leadership or health system leadership? Just curious.
I think there are leaders at hospitals that understand this issue, but it's going to take a lot to take $200 million worth of strategic capital. When is the board going to say, okay, we're going to invest $200 million in building a new building, adding beds, whatever? But at least 10% of that is going to go into these kind of efforts. It is about really, truly reallocating dollars at a level that can make a difference. We're not talking about pennies and dimes here. We're talking about millions are needed. But we have millions if we would just allocate them differently. And I think when boards can see that those investments have a return, and you can show even sometimes the financial return to the organization, but you can show a community return, a return of really improvement in health, which is better for everybody, right? So I think we can do it. We just really, truly need to find those leaders and really push this envelope.
That's great. And Ryan, maybe I flipped the question a little bit. maybe you can kind of provide some perspective more from, I guess, the health plan leadership, points of view. In that, what would it take to get more MCOs, like in a similar way, to invest in, in social determinants of health or non-medical driver of health needs of Medicaid beneficiaries?
So I'll actually start with hospitals and then go back to the MCOs and just a couple examples of work that I'm excited to see as this kind of needle continues to move. Many of you in the room are probably familiar with DSRIP, the Delivery System Reform and Incentive Payment Program, and we've kind of phased out of that. The Health and Human Services Commission has moved forward with a variety of directed payment programs. One of those is specific to hospitals. I think there's about 300 hospitals participating. We love acronyms. In CHIRP, the Comprehensive Hospital Increase Reimbursement or Payment Program. And one of the things we're talking about for the third year is we should probably include some type of a metric about social determinants of health. It's a small thing, but let's start with the process metric. We have a similar program called TIPS, the Texas Incentive Payment Program for Physicians and Other Professionals. And there already is a metric about those providers screening for social needs. And again, it's more of a process metric. Are you doing this or are you not? But it's a place to start. And I also want to comment on the return on investment issue, the ROI issue. And this is more of Ryan coming out than the state of Texas. But from my chair Medicaid programs, we're covering life-changing medications, gene therapy for conditions such as thalassemia and sickle cell disease. That costs millions of dollars. And I am happy that we are able to cover those and serve kids and families in that way. But there's no ROI calculation that Medicaid programs do. If a drug goes on the rebate program for the federal government, Medicaid programs cover those with a few exceptions. Yet the pediatrician in me coming out is that yet we have to prove that there's a return on investment on giving someone with diabetes healthy meals that's going to help address their condition. And so that's just more of a commentary there. But I think a lot of this just comes down to forming relationships. The fact that we are having this and talking about this as an issue and highlighting this is huge. And again, I'll just go back to the Learning Collaborative that's really viewed as a national best practice. You may know that Medicaid in Texas accounts for about a quarter to a third of our entire state of Texas budget. And so, those dollars are appropriated by our legislative leadership in Austin, who are almost concluding the 88th legislative session. And there's that pot of money, but I don't necessarily see a whole lot of infusion of additional dollars. And so how can we use the dollars that are already in the system? And we know that the managed care companies are doing this to a decent extent.
Great, thank you so much. Doing a quick time check. I'm going to open this up, and I'm sure there are many of you. Okay, let's go with you first.
I'm very curious from you, who is doing this across the country? Is there if there are hospital systems that are actually engaging in this? I'm curious if we have best practices someplace else that we could use. That's going to be very hard to dislodge the dollars from them. So who is doing that? How do they do it?
So we had a conversation earlier that it's really hard to tell. So one is there's a lot of hospitals reporting and engaging in the community benefit spending, but oftentimes and sometimes you see a lot of like advertising of like the amount of dollar amount. But in general, it's hard to know how much is it just talk and noise versus how much it's actually, in terms of how much is actually going into the community. Because somebody brought up in an earlier meeting that it's hospitals going and saying, look how great we're doing into the community. It's actually direct advertisement for the hospital. There's an interest for them to have patients flow into their hospital system. There's an interest in them saying how great work we're doing. But the issue is that there is no regulation nationwide to dictate how much should actually be flowing directly into the community versus how much should stay with the health system to serve, kind of what the health system thinks it should be doing. But to answer your question in terms of are there certain health systems that are doing a great job? Most people point to the systems that tend to be more vertically integrated, where they are, one, the reason is because they're accountable for total costs of the patient population, and one, they own the health system. So Kaiser, for example, is one that you often hear about, because there, when people talk about ROI there, if you're a fully integrated health system, now there's some cons to it, but in terms of the pros, if you're a fully integrated system, everything you invest into the system in terms of reducing the social determinants of health will potentially come back in savings in the future. If you're able to reduce rates of obesity, rates of diabetes, rates of like hypertension disease, cardiovascular disease, you'll see fewer of those dollars because they're, everything they do, they all see the return. In the general healthcare system, though, it's really hard to figure out like investments into the social determinants because everybody, people switch plans constantly, and investments from a particular MCO, the ROI may not be seen if that person then leaves the plan and go to another plan. And so it's really hard to get accountability right in our healthcare system, because also, hospitals are separated from the nursing homes, and the nursing homes are separated maybe from the primary care doctors, and the primary care doctors are separated from the specialty. So it's hard to figure out who is truly accountable for the total cost of care. And one trend we're seeing now is that the federal government is pushing people into accountable care organizations, because maybe there's an ability to sort of care for the whole person and not just pieces of the person.
One other model that I'd call out was an opportunity, a pilot. We love pilots in Medicaid. It was a 5-year pilot program supported by the Center for Medicare Medicaid Services, CMS, called Accountable Health Communities, or AHCs. I think there's 33 locations across the country. We have 3 in Texas, Houston, San Antonio, and Dallas. Actually, there was a paper just published in Health Affairs about this. It's a pretty successful model where you have a community that is targeted to address health-related social needs, and there's a bridge organization, as it's called, which is usually a hospital or a health system. Some of the key findings from that paper I just mentioned were the spend wasn't less for people that were participating, but there were fewer ER visits for individuals that were receiving care navigation services through the AHC model. So something to learn from and apply as we move forward.
Yeah, I think there are numbers. For instance, we do know that when we navigate a patient from our ED into a primary medical home, and we look 12 months back at their history of use and 12 months forward, we'll see a 60+% reduction in ED use. So it is giving people the tools that they need at the time they need them and in a way they can use them. And we have not been very good at that in the past. And we have to really get better of identifying those issues and really giving people the tools. We participated in the accountable communities, and you find 75% of your patients have at least one identified issue. It's just not poor people. It's a lot of people that have some of these issues. So it's not only asking the question, but it's really doing something about them. And that doesn't have to be new. You can link to all the wonderful resources that we have, but you have to do it in a way that really connects the patient or the person.
Great, thank you. Any other questions or comments? Okay, yeah, go ahead, Rosie.
This one's for Ryan. As the leader in the state Medicaid program, has the state ever considered thinking about giving better direction to health systems about priority health indicators? Like maternal health is abysmal in Texas. And so there really isn't a way, and while the hospitals are all saying we really want to make sure and take care of these moms prior to their pregnancy, during pregnancy, postpartum, there really aren't any hey, systems, if you, in your community benefits, you might want to think about trying to invest and encourage or incent them to do more collective initiatives or on violence prevention or whatever. Because I do think that is where there seems to be that disconnect even on district. There was this kind of we kind of flew by each other with regard to how we were going to look at significant health outcomes and measures in that regard.
So I love this question. So for the first time in the history of the agency, HHSC, the Health and Human Services Commission, has a non-medical driver of health, as we call them, action plan, which is publicly posted on the website and prioritizes 3 issues. We want to give direction to our MCOs, our providers, to include hospitals, and you will not be surprised to hear that those are food insecurity, housing, and transportation. So it's not going to address every single issue, but we felt one of the roles that we can play as the Medicaid agency is let's prioritize a few things as we move forward. If you Google search HHSC Non-Medical Driver of Health Action Plan, it will come up as the first hit. This really builds upon work as we transitioned out of DSRIP. There was a milestone report that we wrote that included, thanks to good work at the UT School of Public Health across the street, the first ever Medicaid specific study done in Texas Medicaid looking at health-related social needs. So we're really building a foundation, and we see this as a really great opportunity to help give direction. There's really 4 kind of goals in that plan, which I won't go through in detail, but one of them is collaboration, and that includes hospitals and health systems working with community-based organizations. I think Jose gave an example of partnering with food banks, and we know that work is being done. So we certainly hope that that action plan will help set a tone and a direction. It does not allocate additional dollars at this point in time, and we would look to our legislative leadership to help us with that. But this action plan is a huge step.
Great. There was another hand up. Yeah, please, yeah.
Thank you for your comment. I'm actually a maternal fetal medicine physician, and here's one of our fellows that I work with as well. And I work at 2 hospitals locally. One's a safety net hospital and one's a nonprofit. And we're looking at how to go about screening for social determinants of health. And so one of the questions that I had is, are there models out there? You just talked about food insecurity, transportation, housing. We've done some screening, but what is the best approach? Because I think a lot of people talk about screening, but don't really, we could do the process measure of screening, yes or no, but what are we doing with that information and how are we connecting them? So is the best approach, we're globally screening for everything, we're picking one thing and screening for that and making sure we have a partner in the community to address that? Is it we're asking our patients, what are your needs, and then we figure out where to target from there. So are there models of approaching this that are more successful than others?
Do you want to take that? And then I think Elena wanted to provide some comment too.
Yeah, I don't know the answer to that question. And to your point, there are lots of different things that are happening, and I think some of them are working well and others not so much. A couple things, and this comes from also kind of frontline experience being a primary care pediatrician. We are screening in our office, which is based in an academic medical center where I practice in San Antonio, using a evidence-based validated screening tool. We know that the managed care companies, during their outreach call, when a new member enrolls in the plan, they're doing screening. Hospitals are doing screenings, and none of us are sharing information and data with one another. North Carolina is really viewed as a national leader. They have one single dedicated system for the entire state that is a closed loop referral system. So all of that data is captured in one system. Their legislature appropriated millions of dollars for this to happen. We haven't done that in Texas. Let's put it there. And so I think it's again, folks in this room that are gonna have to figure out, and I think this point came up earlier, I don't think we're doing a good enough job asking the people that we serve what works best for you. I don't think getting screened for everything every single time you encounter the healthcare system is the best way to go about this. And as practicing providers, this is one more thing we're asking primary care docs or specialists to do. I don't know what the answer is yet, but I think we're getting closer.
Carol, yeah.
I think one of the things we have to think about, do we really want to screen? Or with the data sources that are out there today, can you buy the data at the individual patient level that gives you the trend? And you can. And if we really put that data to work, both at a community level, so we can see the trend from a community level, where are the transportation issues? Where are the food insecurity issues? But you can also meld it to the individual patient in person. And we could buy that data one time at a community level and share it. would we all be better off, and could we move further? Because we've got to get past process measures, and we've got to get what are we actually doing about the issue, and are we changing the issue? And changing the issue really at the upper level. So connecting somebody to the food bank is great. It gets them food this week, this month, etc. But it does not cure their food insecurity issue. So we have to think about the Band-Aid, which is the today, but we have to think about the broader issue. But I think we need to think differently and broader, and use the tools that are now out there to really change the scope.
Great. Elena, you want to?
I want to put in a plug for a new organization that is founded by Rice's Baker Institute with our partners at the UT School of Public Health. And it's called the Texas Consortium for the Non-Medical Drivers of Health. And we founded this organization because all of this work really is accelerating, and we want to build a field of practice so that you have an opportunity to talk to others who work in your space and ask those kinds of questions. And we're hoping that we get broad participation. We are starting with our first offerings actually in the first 2 weeks of June, where we're having online webinars. One is on food insecurity, and I think we have somebody who's part of our steering team here on that. We have one on evaluation, and we have one on community-based safety net providers, and those are specifically talking about how you screen, whether you screen, what you do when you screen. And so if you will, if you registered for this, we probably put you on our mailing list already, but we are galvanizing people who are working in this space, and it's a huge project for Rice and for UT, so please join us.
Great. Any questions? Or I saw some hands. Okay, you and then you follow. Okay, go ahead, Amy.
I'll be very brief. I just have a brief comment. Love listening to the panel speak about this. We're not effectively capturing the lived experience of the people we're talking about, and we're not capturing the lived experience of the providers in clinical care. What you said, Dr. V, really resonates with me, having provided clinical care in the past. And as a student of the School of Public Health, I would like to put in a brief shout out for qualitative and mixed methods research. Because yes, Dr. F, those numbers, being trained in epidemiology, are super important. But what's behind those numbers, what colors those numbers, is the lived experiences of the people that we're talking about. So I'd like to put a plug in for mixed methods research when we're working on all the things that we need to do.
Great, thank you. Let's go with go to her first, and then Jackie. Yeah.
That's so funny that was your question before mine, because as I understand, the Community Health Worker Program for the state of Texas has the strictest or the most rigorous requirements for that certification, which is, in theory, I understand, supposed to be, those community health workers are supposed to be a little bit of a bridge with the communities, actually being part of the communities and understanding what's going on. Have hospital and healthcare systems embraced that idea, and those community health workers figured out how to use them?
Yeah, we employ them in multiple places. We employ them in our ERs. We employ them in our resource centers. We employ them in our school-based health systems. So they are that great bridge to take people and make those connections for them. And they're a great resource. We just need more of them.
And Dr. Wee, do you want to comment on HB 1575?
Yeah, so we also know that the managed care organizations work with community health workers in a variety of ways. Right now in Medicaid, community health workers are not a separately enrollable provider type like a physician or a nurse practitioner or a psychologist is. However, I believe there is a bill that is sitting on Governor Abbott's desk, House Bill 1575, which was authored by Representative Lacey Hull, who I believe is from the Houston area, and carried in the Senate by State Senator Lois Kolkhorst, which does quite a few things. One of them is it directs the agency to come up with screening standards for pregnant women entering Medicaid, and so that's kind of exciting. We'll obviously be working with stakeholders like yourselves to do that, but it also allows both doulas for the first time and community health workers for the first time to deliver case management services through a case management program that Medicaid has operated for years. So it's not a separate provider type, but again, this is incremental change, a step in the right direction that I certainly hope will make CHWs more accessible and used more commonly across Texas.
Great. And Jose, anything to add from a national perspective?
The one thing in terms of the national perspective is in terms of the comment earlier about standardizing the way we screen for social determinants of health or non-medical drivers of health is for the first time, the Centers for Medicare and Medicaid is requiring all hospitals to report on the proportion of people that are screened for common social determinants or non-medical drivers of health. And it's a very standardized approach. And one reason is because if we're not measuring things the same way and we're not talking about the measure in the same way, then it's really hard to learn from one another. And if hospitals just need to report it, it's going to be mandated. If they don't, if they take a Medicare dollar, then they're going to be penalized for not reporting it. But we talk a lot about the so what, like just screening alone is important and it is necessary and is the basic first step. But the so what our hospitals and health systems are going to be doing with that information is still unclear. But the hope is that if we're talking about the same type of social determinants, the same type of social needs in the same way, that it will help facilitate cross-learning, for example, in the initiative that you just mentioned today. But
That's great. Yes.
I've always been so impressed that we have the world's most expensive medical system. We have the world's largest medical center behind us, but we're not rated number one. We're pretty far down. If we address some of these community needs, will our standing in the quality of world healthcare rise, or will we still just be the most expensive and with kind of a fair
I spend a lot of time comparing ourselves to other countries using data. If you have a heart attack, the likelihood of you surviving that heart attack is among the best in our country. Our country's healthcare system for acute care is among the best, arguably the best. Cancer care outcomes among the best in the world because of the fact that we provide really good, high quality, complex healthcare to people. But as we talk about, that is only part of what ultimately determines how long we live and how healthy we live. But in our country, we've allowed our healthcare industry, our healthcare business, to dictate a lot of how they're paid and how much they're paid, whereas other countries have a lot of regulation in terms of regulating healthcare prices, regulating healthcare consolidation, regulating, for example, drug prices. In our country, for the same exact drug, we pay on average 2 to 3 times more for the same exact drug, which is kind of ridiculous because the taxpayer in the US is often the one paying for the R&D that developed into that drug, but yet then eventually when it comes to market, we pay 2 to 3 times more for it. And so it is a system that is just, it costs a lot of money to care, and a lot of the dollars flow into the healthcare system, and whereas other countries are more judicious about flowing dollars into the sort of the non-medical drivers of health. And so there's a lot of data that suggests that other countries invest much more on social spending than we do in our country. And so that might be part of the equation.
I'm pleased to hear that for our most popular ways to die, heart disease and cancer, that we get good care. So what are we falling down?
We're really good at treating sick people. We're not as good as preventing and keeping people out of the healthcare system and all that stuff. So it's the question is, like, we as a country have decided to focus on providing really good sick people care and not necessarily thinking about whole person care and having the system to sort of keep people out of the hospital and healthy.
Great. I think, Tanvi, you have your hands up, and then we'll go to this gentleman, and then we'll come to you. Okay. Go ahead, Tanvi.
Great discussion. Just not a new question for a lot of people in the room, but given the negative incentives for hospitals to not have patients, obviously they get paid for getting patients in. we saw during COVID, they had negative lesser margins because they had less people coming in. So given the sticks and carrots that are lined up right now, what's their motivation to get more involved in SDOH, which would potentially have less? I mean, 'cause I heard some comments about potentially some reduced, some improvements in costs and all that kind of stuff. But realistically, for hospitals, what's their motivation to actually get involved with doing this in a serious way?
I'll just maybe
18% uninsured. They don't get paid for those. So if we can reduce the use of the expensive resources by doing things in the community and keeping people healthier, there is a return. Plus, nonprofits are community-owned assets. They are owned by the community for the benefit of the community. And we really need to stretch what we're asking of our nonprofits to really live up to that ownership.
And I'll just quickly add, a lot has to do with how hospitals get paid. So that's true in a predominant fee-for-service healthcare ecosystem. Hospitals survive by the more they do, the more they see. And so that's why there's such a huge effort to switch people into sort of whole person type capitated models of care. Sure, that exists on the MCO side, but it doesn't necessarily exist on the healthcare side unless the system is vertically integrated. They control both the insurer and also the provider. But there's a lot of bad in vertical integration. I mean, we can talk for days about the dark side of that kind of model. But what we really do need is to think about, the healthcare system needs to think about and be incentivized to take care of the whole person, not just the heart attack, not just the knee replacement. I mean, as people, like, so you want somebody to take care of your whole needs and then take into account your non-medical drivers of health as well. And so we need to move away from pure fee-for-service. That's the only way to do it.
Great, thank you. Yeah, please.
Yeah, thanks. I'm Drew Helmer. I work with the VA here and Baylor College of Medicine. And I think what I'm hearing today is we're asked, the title, we're kind of asking hospitals to take on additional responsibilities that I guess I would attribute to public health or, even, I guess the infrastructure part of our government, right? I think one of you mentioned building roads. That's the last thing I would think a hospital would do. So what?
I built a sidewalk.
Well, so I guess, are hospitals really the right place to be doing this work? I mean, if we're going to be kind of maybe squeezing some resources out of the healthcare system in order to do this, are the hospitals the best people to be doing some of these interventions? And you've talked about the fact that hospitals need to partner with community organizations or other organizations, but I'm not convinced that hospitals are really the right place to be.
Yeah, and I agree with you. Like, again, if we were to redesign who would be responsible for meeting the needs of the community, why would you want hospitals to do it or the healthcare system to do it? Are they the right stewards of the money? Are they incentivized to invest in the community? And I think you're exactly right, but the reasons why they're currently being involved in the conversation is because hospitals are 1/3 of all healthcare dollars in our country, which is, we're paying them a lot. And then the other thing to note is that, the healthcare industry in our country is among the most profitable worldwide. There's a lot of profits. There's a lot of, and there's an argument that there's a lot of nonprofits being made by the nonprofit hospital system. And those dollars, there's a reason why they're making nonprofits. It's because we're paying a lot for the healthcare. And so they should be accountable into also meeting the needs of the community. And if not, we should think about how we're reimbursing the healthcare system. One quick example is, imagine if the nonprofit, if all hospitals were taxed one day, and the $30 billion, it's like, okay, it's no longer your responsibility to provide community benefit spending. We will take care of it. Local governments will take care of it. State governments will take care of it. Federal government will take care of it. That is one potential solution. It will be controversial because I'm sure there's going to be a huge lobbying, But then a lot of people in the room, including you guys, spend a lot of time hopefully counteracting some of the lobbying, or through your own lobbying, I see. But yeah, it's a great question.
Great. Yeah, go ahead.
Mine was similar, because I was thinking hospital, maybe that should be replaced with insurance. How can insurance companies help address? So that's why I was wondering what else could be replaced there besides the hospital to address the social determinants? Because insurance companies are
Also
have a
making
big
a lot of
sway
money.
in this.
Yeah, actually, you know, the year the insurance had record-breaking profits was during COVID. They kept record-breaking profits because they weren't processing claims. People weren't showing up to hospitals, to your point. They weren't. And so there's a big argument as well, is like how much money is going to middlemen, which is the insurance company. And that's another conversation.
We have a hand up, and then we'll come to you. Yeah, go ahead.
I did have a question on one of your slides. I noticed that Texas had a 91% response rate, while the rest of the country had 64%. I was wondering why Texas was so much higher, and to defend Texas a little bit with that, were the other ones not responding because of their poor metrics and what they would have responded to? So actually Texas might have looked even better.
It's a great question. So the results are, we do weight by the type of hospital that responds. You're exactly right. Safety net hospitals are less likely to respond nationally. Rural hospitals are less likely to respond. Smaller hospitals were less likely to respond. But when we look at the results, we give less weight to the hospitals more likely to respond. So they're being represented. The 64% is being stretched to look like nationally representative. But you are right that it is possible that the fact that we had nearly 100% of hospitals responding, including almost all safety net hospitals, could be maybe driving the average. The survey weighting does away with it a little bit, but not completely.
Great, thank you.
Are you my reviewer? Were you the reviewer? Reviewer number 2 over there.
Well, I wish we have another 30 minutes or so, but we only have time for one last question, and I'll let her ask away.
That's a lot of responsibility. I'm interested that nothing that I have heard really specifically deals with the role of elected officials, be it state, local, national, in this dialogue, and what, especially in Texas, with the refusal to deal with expansion of Medicaid, I keep thinking, is there a role? Is there a need? Is there an opening for more education? So much of what was said, has been said this afternoon, is so vital, but we all believe this in some fashion or other, and we keep having this barrier with elected officials, not hearing what's being said and not, in my opinion, being willing to be educated. So that's indicating my bias, and that's why I was afraid of being the last one.
We do have one more. Can I be the last one? She can save you from being the last one.
Oh, good.
Just a comment to why I think hospitals may bear some responsibility, and it had to do with Dr. Figueroa's early chart, the chart we know about social determinants. So if certain communities don't have sidewalks or access to doctor's offices or transportation, they know they can go to a hospital because an ambulance would bring them there. Now they may have to figure out how to get back, but they have access to that, and so that is one place they go. So since they are there and spending a lot of time there because they don't have the connection to the other things in their communities, nutrient-dense foods, things like that, then they do present to the one place they know can't turn them away. So that could be why hospitals could bear some of that responsibility.
Great. Do you guys want to comment on the last or?
I'll just say one quick thing. You would hope that we would live in a society where politics would get out of the way of doing things we think are right. EHF does a poll every year that shows the majority of Texans would support Medicaid expansion every year, and it's wavering a little bit, but it's still the majority of Texans, including Republicans, conservatives, and independents, although I think the independents in Texas in Massachusetts, we call them Republicans. I'm from Texas, by the way, I should say. It's just, you would hope that politics would get out of the way. If they were really supposed to be representative of the people who are in favor of expanding Medicaid, you would think that it would happen, especially when it wouldn't cost the state a single dollar. There would be federal dollars flowing into the state. And my colleague Adriana, who's from the Harvard School of Public Health, had made a comment that other states have managed, including very conservative states, have managed to pass Medicaid expansion by the argument is that Texas is paying tax dollars. The Texans are paying taxes that then is used at the federal level to subsidize Medicaid expansion in other states. But somehow the state is okay for their tax dollars being used for other states to expand Medicaid and cover people who need it, but somehow are not. And so it's just, you would hope that politics would get out of the way, but unfortunately, we live in a society where that has yet to play out. So hopefully, if anybody, maybe more lobbying dollars to get them out of the way.
Well, on that note, wanted to invite all of you. We have a small informal reception right outside. If you want to continue the conversations, have some one-on-one with any of the speakers, panelists, please, and on behalf of Baker's Institute and Episcopal Health Foundation, we wanted to thank you so much for spending the time with us on the Thursday afternoon, and also heartfelt gratitude to Jose, to Carol, to Dr. V for coming. Thank you so much.